Good afternoon and welcome everybody. My name is Cecilia Baumgartner and I am the European Project Coordinator for the Eurotest, including the European Testing Week. I would like to welcome you to today's webinar, which is organized by the Eurotest Secretariat as part of the 2025 Spring European Testing Week. And before I start, I would like to mention a few house rules and announcements. Today's webinar will be 60 minutes and we have 5 expert presentations followed by a plenary Q&A session. And in the interest of time, we ask you to please submit your questions through the Q&A section in Zoom during the plenary Q&A session. The webinar presentations are being recorded for the purpose of posting on our website, so as a long-term resource available to a wider audience also. Please note that it's only the presentations that are being recorded and not the discussion, which will not be posted online to ensure compliance with GDPR regulations. And we also ask you to kindly not use any AI tools for recording this webinar because of GDPR reasons, and remind you that we will be making a GDPR compliant version available on the website of European Testing Week. Just to mention that the topic of this webinar is framed within the overall theme for European Testing Week in 2025, which focuses on migrants and mobile populations and the right to health for all. We've produced a theme statement as we do every year, and that highlights some of the structural barriers that put these groups at increased risk of catching infectious diseases and at the same time prevent them from accessing healthcare services such as testing and linkage to care. The statement includes information that you can use for advocating for better access to testing for these groups, and it also includes recommendations for implementers, as well as a number of relevant resources if you want to know more about this topic. And this statement is available on our website for Testing Week, and you can see the URL at the bottom of the screen for that. And now I would like to pass on the floor to our chair of this session, Magdalena Ankiersztejn-Bartczak, who is the co-chair of the European Testing Week Working Group.
Good afternoon and good morning for those who are in other part of the world. Thank you for everyone for joining. I'm Magdalena Ankiersztejn-Bartczak. I'm CEO from the Foundation for Social Education. It's the organization based in Warsaw in Poland. And I have a great pleasure to be also a co-chair of European Testing Working Group. The overall aim of this online webinar organized by European Testing Week is to highlight key data and to share and discuss practical strategies and real-world experience from Spain, Malta, the Netherlands, and Eastern Europe. Expert presents will share insights on increasing screening and a linkage to rights-based care for migrants and mobile population. After our pleasant presentation, we will have a plenary Q&A session with the audience, so please feel free to write any of your questions for presenters in the Zoom Q&A box through the webinar. And now I have a great pleasure to introduce a first speaker and first presentation. We have Charlotte Deogan, a PhD in public health and expert in prevention and communicable disease at the European Center for Disease Prevention and Control, working on HIV, STI, and hepatitis, focus on vulnerable populations, including migrants. Charlotte will be presenting on the current status, needs, and recommendations for increasing screening among migrants and mobile population. Charlotte, now your turn.
Thank you, Magdalena. As said, I'm Charlotte Deogan. I work for the ECDC. I focus a lot on vulnerable populations, and I work a lot on prevention and monitoring as well. I'll give you a short outline of the ECDC work in this area that might be relevant for the further discussion during this webinar. Any questions you may have, you can email me later or put them in the chat. Let's see. So a couple of years ago, ECDC published a document related to newly arrived migrants, and I mentioned it in this setting because I feel it's a lot of it. It's still relevant. Some of the content is beginning to become a bit outdated, but what I would like to highlight from this is the considerations for implementation that we outlined in the document, because a lot about reaching mobile populations and migrants is about how we're providing the services, of course, not perhaps essentially about what we are providing. And in that document, we outlined the necessity to make it voluntary, confidential, and non-stigmatizing for newly arrived migrants, to provide it to anyone who require it, regardless of their migration status, as well as to address the individual, community, and health system barriers that these populations face. The need to consider the unique needs of each population, in this case, the newly arrived, of course, because they all face very particular challenges and needs, which come into play in how we provide care, as well as to recognize the needs in a wider sense of the life conditions that they face in terms of testing and screening and linkage care might not be their absolute priority at the time that the healthcare providers meet them, but rather other aspects such as housing and employment, etc. But now looking at what the recommendations that we provide when we talk about migrant populations, we usually focus on integration of testing and care, the adaptation of services, as well as the need to break some silos and work more cross-sectionally with a range of stakeholders, not only testing providers, for example. So I'll go quickly through some of these. In terms of integration of services, most of you know migrant populations are not different than any one of us. In many cases, we do prefer an integration in relation to a separation, meaning a one-stop shop for meeting our needs of healthcare. So testing, treatment, vaccination, it could be other issues as well. Depending on the disease, for TB, we usually talk about people-centered approach. For non-communicable disease, we talk about patient-centered approach, but essentially adapting to the needs of the population at risk. And that goes, of course, as well for migrant populations that are no different than any of us. We do recommend this integration of testing of bloodborne viruses, and we also provide monitoring of the implementation of integration in the EU EEA. So this is from a forthcoming report. This shows a map of the EU EEA countries and the recommendations for integrated testing that is included in the national testing guidelines. For example, now for HIV, 17 of the 27 countries that have available HIV testing policies also report that the guidance also recommend integrated testing for HIV, viral hepatitis, and STIs. The light green are countries that provide recommendation for integrated testing of HIV and viral hepatitis, while the yellow is that there's no recommendation of integration. So we still have some way to go there. In terms of recommendations for testing of key populations, this shows the number of countries that have these different key populations in mind. For migrants, we have 21 countries mentioning migrants in their HIV testing policy. We have 19 countries mentioning hepatitis B in the testing policy guidance for migrants, and 18 countries mentioning migrants in the testing policy for hepatitis C. I also want to mention what we perform a lot of country support and dialogue with countries, and these different clouds summarize some of the topics that we hear a lot from many countries, but particularly in the latest country exchange we had on this issue with some of the Mediterranean countries, Italy, Malta, Greece, and Cyprus, that we held in December, in which the focus was on supporting and reaching migrant populations through testing, linkage to care, and retainment care. A large part on cultural and linguistic mediation, of course, and how to put that in place, how to implement it, how to fund it. In relation to stigma and how to reduce that, both in relation to the individual, community, and in relation to the healthcare. How to put in place a bit more of this comprehensive approach of multi-stakeholder collaboration with links to other services, such as social, financial, and housing services, in order to, of course, meet the needs of these populations, as well as how to keep up with the knowledge and up-to-date information on the migrant inflows and how to meet different groups of inflows, as well as cross-border management. All these topics are raised by most countries, of course, a bit more prominent in the Mediterranean area, which have struggled and faced this issue for a longer time and with higher inflows. As for now, in a lot of our recommendations, we do focus, of course, on how to practically bring about testing to migrant populations in different settings, generally to expand the various type of testing that we have in the toolbox into the community. Outreach and use of self-testing is highly recommended for migrant populations, as you know, in order to reduce some of the stigma and to increase the uptake. We also recommend a comprehensive approach to testing and trying to integrate links with other services as well as different types of disease testing, which is likely to address the needs in a higher extent and reduce the stigma around it. Cultural and linguistic sensitive testing program, including cultural and linguistic mediation, is recommended for all migrants, of course, regardless of their migrant status, as well as time in the host country, given their need for repetitive testing for some cases and some diseases. I also want to mention an ongoing work that we have to collect models of good practice of testing, linkage, and retention care. We're doing this now, and our hope is to publish it by next year. You are very welcome to participate and submit your excellent good practices and examples of work of reaching and increasing testing, linkage, and retention for these populations. And of course, the aim of that is to recognize the efforts done by you, by the community, by countries, and to facilitate information of knowledge and experience and inspire to further action in this area. Looking forward to hearing about the country examples. Thank you from me.
Thank you very much for this very, very interesting presentation. I see the hand of Kate, but please put your question to the chat box, and we will use this question and ask our presenter in the Q&A session. We will first of all have the presentation and then the Q&A part. So now we are moving for the next presenter, Camila Picchio from the Barcelona Institute for Global Health. Camila is a multidisciplinary public health researcher, PhD in medicine and translational research, with specific interest in migrant health and personal centered care and experience in health system responses, particularly to viral hepatitis, HIV, and vaccine preventable infection. Her research to data has focused on simplifying diagnostic process by using novel tools and products, linking patients to care and ensuring healthcare services are delivered to the most underreached population, often through cultural and linguistically appropriate intervention. She is passionate about increasing access to healthcare through sustainable and innovative solutions like decentralized and community-based care, and through mindful engagement and working closely with communities and civil society organizations. As you can see, she has amazing experience. So now, Camila, the floor is yours.
Thank you, Magdalena, so much for that very long introduction. So I'm Camila Picchio. I'm a researcher at the Barcelona Institute for Global Health, and I'm going to be talking about the viral hepatitis community screening and vaccination program that was implemented in Spain, Italy, and Greece over the past few years. But then I'm going to focus specifically on the Spanish context, which is, of course, where I'm based. I'm going to mention this briefly. I mean, why did we choose these three countries? And that's ultimately because Italy, Greece, and Spain are the top 3 EU countries with the most border entries, as we can see here from data from the IOM, with migrants primarily arriving here from the Western, Central, and Eastern Mediterranean migration routes. So Viral Hepatitis Community Screening, Vaccination and Care Program, or VH-COMSAVAC, or COMSAVAC for short, was an EU co-funded project with the aim to scale up community-based models of care to increase hepatitis B and C testing and hepatitis B vaccination and linkage to care, specifically for migrant and refugee communities. So as I mentioned, this was implemented in these 3 countries. However, we did have a pilot program that was implemented prior to this phase between 2020 and 2022. And I'll provide an overview of some of the latest high-level results from the greater project, but I will also present data from the whole pilot program here in Catalonia that's been taken over, that's been ongoing for the past 5 years. So ultimately, this isn't particularly new. I'm sure many of you are working in this space, but it's a community-based model of care where testing for hepatitis is decentralized. Positive results have direct referrals to specialist care, and negative results, I'm just going to focus here on the Catalan setting, have the component of decentralized hepatitis B vaccination, where we actually administer the first dose of the vaccination series in the community. And we were able to do this through the use of plasma separation cards, which I will explain momentarily. So when I say community, I mean, it really can be anywhere: community spaces, religious spaces, cultural festivals, women's associations. In other settings, in Greece, for example, was also included in the prison setting and during street outreach. We used tools, like I mentioned, the plasma separation card, which may be unfamiliar to some of you, which is similar to a dried blood spot. However, it actually separates the plasma from the whole blood and is much more stable. So this allows us to really work in any type of setting across the community. And of course, rapid tests that we collect from capillary whole blood or through phlebotomy as we do for the DBS. Resources, importantly, are having culturally and linguistically appropriate information. So these material were developed and translated into relevant languages. And of course, having a dedicated on-the-ground team. We employ community health workers or community health agents who are part of the migrant communities that we're trying to reach, and having a dedicated community nurse working on the ground. We also, very importantly, as I mentioned, have direct referrals to specialist care. So this means that we kind of bypass primary care in this sense, because here in Catalonia, viral hepatitis is managed at the tertiary level. So these are some of our collaborating hospitals. And of course, having support from the regional health authorities early on was very important. So if we're just looking at some quick data from the European level program, we screened more than 2,000 people. We're relatively young. They arrived to the EU less than 5 years ago. So for the most part, recent arrivals, overwhelmingly males, and primarily from sub-Saharan Africa. And if we see here on the right, among those who reported traveling by foot and sea to reach the EU, they were indeed carrying out the Western, Central, and Eastern Mediterranean routes. If we see here, we have the breakdown by participating country. So here we have Greece, we have Italy, and Spain. So very clearly coming through the Eastern Mediterranean route, through the Central Mediterranean route, and through the Western Mediterranean route. Our overall hepatitis B prevalence was 3.5, and for hepatitis C was 2.9, so about 3%. However, we did see some variability across the countries, as we can see below, with hepatitis B surface antigen positivity reaching about 6% here in Spain, and reaching 6% for anti-HCV in the Greek setting. And that can be explained primarily due to the country of origins, or the birth regions of origin across the sites, where in Spain, we primarily saw sub-Saharan African migrants versus in Greece, Eastern European and participants from the Middle East. If we're just looking at Catalonia specifically, again, similar, but a little bit different. The profile over the past 5 years, we've screened an additional 1,000 people, also relatively young, predominantly male, from sub-Saharan Africa, and only about a quarter in this population were recently arrived migrants, and again carrying out that Western Mediterranean migration route to reach Spain. In our setting, our hepatitis B prevalence reached 8% and a little bit less than 1% for our anti-HCV. But importantly, we were able to link 71% of them to care, which means that they had a first documented visit with a collaborating tertiary level hospital. Among those who were negative in the case of hepatitis B, about half were eligible for vaccination because we were able to look at anti-core. And these participants, 44% of those were offered vaccination in the community. So that first dose of the hepatitis B vaccine actually brought into those community spaces. And importantly, 83% of them accepted actually that vaccination in the community. So this is something we did it for all 3 countries. Just for sake of time, I know I have about a minute left. We also carried out a value-based assessment, which aims to evaluate kind of the impact of these interventions, not just in terms of case finding. And if we look here at Spain very quickly, we see that these community-based strategies have added value, specifically for the patient experience. If we just look here at the top, in terms of cultural sensitivity, provider empathy, and the likelihood to recommend, were highly valued by the participants, but also by the staff. And things like long-term sustainability and cost are something that are more problematic. So some key factors that led to the success, we had support from the health authorities early on. We used point-of-care testing and simplified blood sample collection tools. We were able to guarantee universal health coverage for any migrant who was in an undocumented or irregular migration status, had linguistically and culturally appropriate material, and of course had a multidisciplinary collaboration. But some challenges we did have were training of the community health workers, because there's no standardized tool guide or teaching material for these populations. The vaccination delivery, as I mentioned, only about 40% of those vaccination doses were offered in the community spaces. The rest were sent to their primary care. And we had a really good job at having linkage to care, right? That first visit with the specialist was great. However, something we're seeing is long-term engagement is more of a challenge. So understanding that health is a basic human right, and once you have funding secured, which is always an ongoing problem for this community-based work, some recommendations would be to ensure collaboration and communication with the relevant authorities at all levels and early on, engage with the community early on, and use participatory-based research methods to design the interventions. Point-of-care testing and rapid detection and simplified blood sample collection tools are your friends, and hopefully, if you can, incorporate them. Ensure that person-centered referral pathways are in place, and implement robust data collection and management protocols for effective monitoring evaluation, so that then when we can report back to the ECDC, everything is very, very harmonized and easy for them. So hopefully with all that together, you can also have a successful and impactful community-based program. Thank you so much.
Thank you very much, Camila, for very interesting presentation and good case from the local project. Now we'll move for another second country presentation, and I have a great pleasure to introduce Dr. Valeska Padovese, who is leading clinical at the Genitourinary clinic in Malta. Her main clinical and research interest is skin and sexual health in migrants and other vulnerable groups. She has participated in numerous EU-funded projects addressing sexual health needs in hard-to-reach populations. She collaborates with WHO on implementation and evaluation on STI point-of-care testing and is a technical advisor to WHO for capacity building on health and migration. We don't have so much time, so I just only mentioned that she has a huge experience as an editor on British Journal of Dermatology and also BMG and STR Journal. And in 2023, Dr. Padovese was the president of EUST, European Congress in Malta. She co-founded an international NGO, Bridges for Health and Rights, operating in the broad area of health and rights and the intersections of disciplines such as medicine, law, and criminology. Dr. Valeska Padovese, the floor is yours.
Thanks, Magdalena, for the introduction, very long. So I'm going to talk about our Reach Out project, the integrated STI testing into community healthcare for hard-to-reach populations. And for this, I have no conflict of interest to disclose. My outline, so briefly introduce also the background of the project and another project we run in Malta and the decentralized sexual health services. I also discuss about community testing using STI point of care test, and I will quickly conclude. So just to give you a brief background of the Maltese context, Malta is a small island in the southeast, the most southern European member state, located in the middle of the Mediterranean Seas, and is also the most densely populated country in Europe, with now over 500,000 inhabitants. And in the recent year, the last census in 2021 showed that the population increase of over 100,000 people, and 1 in 5 of these persons are foreigners, so migrants, with an increase of more than 5 times in the share of foreigners since 2011, mainly people coming from Southeast Asia and South America. The background of the Reach Out project is another project, it's named SCAP, starting in 2021 and funded by the European Academy of Dermatology and Venereology, a multi-center study run in Malta and in Lebanon, based on a skin and sexual health assessment in migrants and refugees via outreach clinics and the administration of a CAP questionnaire, so a knowledge, attitude and practice survey, both in open centers and reception centers for asylum seekers and refugees, but also in migrants detention center and at the main sexual health clinic where I work. It was a 2-year project, then because of COVID there were some delays, but the project concluded in Malta last year at the end of 2023, beginning of 2024. And this is the map of the island with all the outreach clinics that were starting in the different reception centers of the island. The methodology very quickly involved first mobilization of the community, including both the migrants community, but also meeting with the key stakeholders and migrants NGO, the use of information material and posters stuck in the reception center or information material given through to the community, the involvement in the project of cultural mediators, so people from the same community that were helping us to bridge not only the linguistic differences and barriers, but also to bridge the different culture, our culture and the migrants' culture, like you see in the photo during a medical consultation, and the involvement also primary healthcare doctors, so GP, general practitioner, working in the reception center for also case finding, information of the population in the migrants reception center, and case referral to the sexual health clinic. I want to summarize as a background of my presentation the data from SCAP project. So overall, we don't need to go through into detail to this in this table, but we can see that there is a higher prevalence of STIs, mainly bacterial STIs, but also HIV and viral STIs in the migrants population that we reach via the projects. And there is a significant statistical difference with when we compare the diagnosis and the prevalence of STIs in the migrant population versus the European population attending our service, and in the data used and collected via the sexual health, the GeoClinic database. So the data were all harmonized. And this slide summarizes the result, the outcome of the CAP survey, of the knowledge, attitude and practice surveys on a sample of 243 migrants. And what we noticed also, our sample was mainly composed by migrants from male migrants, men, young, and coming mainly from Southeast Asia and the Sub-Saharan Africa at the time. And there was overall a poor knowledge about STIs. Somehow there was a knowledge, they were aware about HIV and HIV prevention, but only concerning use of condom. And there was, the questionnaire report still a high stigma against HIV and related to cultural belief and religious beliefs, and the practice highlight lack of use of condom and engaging in high-risk behavior, plus some migrants were reporting personal history of violence and sexual abuse. At the same time, the Ministry for Health decided to decentralize the sexual health services in Malta, so we started implementing and opening community clinic in primary healthcare setting and integrating them with the use of point-of-care test. Also thanks to a collaboration with WHO and the project, a multi-center project that led to the validation, a clinic-based evaluation of point-of-care tests, both for syphilis, HIV, and for chlamydia and gonorrhea. And this is our nurse, the nurse who is taking a point-of-care test to one of our patients. The Reach Out project started in 2023, where we first implementing and identify setting for outreach activities. So we started operating clinic, integrating sexual health clinic in the Migrants Detention Center in Malta, but also in correctional facilities, and more recently in the substance misuse outpatient unit. These are photos from the 3 new settings where we are operating. The substance misuse outpatient unit see overall 1,300 active patients every year attending for the daily methadone. And after training GPs working in this setting, we are managing to integrate sexual health testing and also treatment. Is quite innovative because in this case, patients are not referred to the sexual health clinic, but are treated directly in the community. We also try to increase awareness in a community setting like the Migrants Reception Center through some activities, focus group, and raising activities aiming at raising awareness like the World Skin Health Day or during the World AIDS Day last December 2024. So the Reach Out project is a project that foresees a collaboration of 3 countries, Italy, Malta, and Greece, and 5 partners, mainly NGOs and research center. Malta is the only government entity part of this project in a consortium. Is a 3-year project funded by the European Union. And the main objective is that of improving the health outcomes for migrants and other local disadvantaged population to prevent and early detect and increase link to care for communicable diseases, mainly tuberculosis, but also HIV, STIs, and the hepatitis. These are other main specific objectives of the project. Among these, increase awareness about prevention, but also promote capacity building and national and translation sharing of best practice and the multi-stakeholder cooperation, sexual health in a vulnerable population. And this is the ambitious target of the project. I go very quickly, but we are aiming also through the use of new technology, for instance, the social media, to reach migrants also in terms of increasing awareness about prevention and increasing education about STIs. The activities will be rolled out also through mobile clinic in the 3 countries partner of the project, so in Italy, Malta, and in Greece. In this project, there is a training component. I'm showing this because Malta was leading the training component, so we produced some generic modules addressing background information, including cultural competency and holistic health in migration, and the medical module addressing mainly communicable disease, but also STIs and skin disease, and mainly based on case studies. Some photos from the training that was delivered in last October 2023. All the partners of the project attending this training in Malta. And to conclude, remaining in the time, I hope, so what we knew, thanks also to the SCAP project, is that migrants from low and middle income countries arrive with and have a higher prevalence of STIs compared to Europeans because of different reasons, higher prevalence in the country of origin, but also lack of education, knowledge, and awareness about STIs, because often they are victims of form of sexualized violence and other vulnerabilities. And so this is an ongoing risk also in the country after their arrival. And there is a high stigma in the countries of origin that prevent them from testing. And so we have to work on all these components. And what we have to do to overcome this barrier is mainly, in my opinion, training primary healthcare workers, doctors at community level, and integrate the primary healthcare community setting with sexual health education and the provision of testing, mainly point-of-care tests, for sexually transmitted infection, offer sexual health promotion to increase awareness, education, and link to care via a structural referral system. And with this, I conclude. So we are also part of a new project, which is called Prospero, together with WHO, which we are trying to evaluate this model of decentralized sexual health service or sexual health service provision at community level to optimize STI point of care test implementation in Malta, but also as a model for other countries wishing to roll out the STIs point of care test. And with this, I close, and I thank you for the attention. This is my email also if you feel like reaching out with some specific questions. Thank you.
Thank you very much, Dr. Valeska. And for those who join us during our webinar, if you have any question for our speaker, please feel free to implement it on the chat box, or Q&A session will be in the end of the our webinar. And our next speaker will be Iason Farrell, my very good colleagues from Testing Week working group. He is a member of our group since it has started, but he's also the founder and director of Stichting Choice Support Center in the Netherlands. For over 30 years, Iason has successfully developed prevention programs for drug users, sex workers, and people living with HIV, regardless of sexual orientation or gender. Iason was the founding director of the Positive Health Project, and upon moving to the Netherlands, he worked with Correlation European Harm Reduction Network, implementing hepatitis C testing and prevention intervention with EU harm reduction programs. Presently, Iason is the founding director of Stichting Choice Support Center Choices in Amsterdam, and probably more you will know from his presentation. Thank you, Iason, for your time, and please. You are on mute.
Okay, good afternoon. Thank you. So I'm Iason Farrell, the founder and director of Choice Support Center. Choice Support Center is a community-based organization based in Amsterdam. Our services are national. We provide psychological counseling and prevention services utilizing evidence-based behavioral interventions targeting gay men and bisexual men involved in chemsex and LGBTQ plus asylum seekers and status holders inside the asylum centers. Our services are offered online in the centers and through our free national helpline that connects callers to psychologists who speak a different language every day. Sorry, they're doing some construction nearby. Based upon the successful results of our national self-testing campaign we provided during testing week 2 years ago, we now continue to offer self-testing to our clients. Our unique self-testing distribution initiative was based upon research that showed testing in urban areas was lower than in large cities. During the testing week, we launched a self-testing campaign, increasing testing among MSM in urban areas of the country. The campaign objective was to improve the awareness of HIV and Hep C testing, to reduce the barriers to testing in urban areas, and it was specifically targeting people at risk who are not adequately reached by usual testing services. The free anonymous HIV, hepatitis, and syphilis testing we organized during the testing week included volunteers and nurses that also administered a national survey to determine the knowledge and interest among self-testing. The results of the survey was that knowledge of self-test was very low. 80% learned about self-testing for the first time through our campaign, and after learning about self-testing, 75% would consider an HIV self-test next time they tested, and the reason was no appointment was needed. The most interesting outcome of the campaign that resulted from having our volunteers, that not only did the people who showed up to get tested for HIV, but we did 110 tests that included HIV, hepatitis, and syphilis due to the interaction and information that we provided on site. Fortunately, during that week, we had no positive test results. So during limited time, I'll give you more results if you send me an email. But how we overcame barriers to reach the asylum seekers. Our services for LGBTQI asylum seekers started during COVID epidemic when 2 asylum seekers came to our office asking for help. This is when 99% of services were online and 50% were reduced due to the 1.5 meter social distancing. After learning about the lack of privacy that asylum centers have, and the fact that asylum seekers don't have laptops or iPads to access online services, we decided to go directly into the asylum center nearby our office. So we did a 6-month pilot project that was very successful. After 6 months, we were invited to go to asylum centers throughout the country. So due to limited capacity, we developed our free national helpline. And the helpline actually connected callers to our psychologists that spoke different languages. The helpline became a success due to the trust that we earned from the pilot project and gaining the approval from the organization that manages the asylum centers in the country that gave approval to us to visit every center in the country. So through our counseling services, we learned that many asylum seekers were fearful to get tested because they were afraid that a positive test result would sabotage their asylum process, and they were afraid that any information about risk behaviors would also become problematic for their asylum. So to debunk this information, during testing week about a year or so ago, we organized a webinar with an immigration worker, an LGBTIQ liaison worker in the center, and a client to tell people about the privacy laws and consent and to debunk that information. That was very successful. After doing that, we wanted to know, how do we connect people to get tested? So during our screening for all new clients, we do a risk assessment. And based upon the sexual risk assessment, we would offer a test appointment. If they do not want to go to a city test site or be tested by the healthcare workers inside the asylum centers, we will offer a self-test. And what we will do is we will inform them about the self-test. We will find out during our pre-test consultation, when was the last time they had an HIV risk event. We would inform them that the test we provide, tests for antibodies that will only be present after 3 months. Once they are eligible for a test, we will then provide the test. We will demonstrate how to use the test. And for people who are not physically in our office, we will mail the test to them. We will provide video consultations. We will email an instructional video produced by Shore. And for those who want to get tested in our office, we will supervise the testing. And for people who are in other parts of the country, we could actually be with them through a video. So no one tests alone. We also ensure that we actually educate them on how to dispose of tests, and we also inform them that we will assist them with partner notification. And this is not really discussed much. I don't hear many people talking about partner notification. So we also explain that a positive test result, we're not going to share that information, and their information is secure with us. So due to the lack of time, if you have any other questions, you want any more information, I'm sorry if I spoke too quickly, but I'm happy to share more information through email.
Thank you very much, Jason, and thank you all of for speakers that thinking about time that we don't have too much. So our last speaker will be Iason Shishniashvili, who is a Georgian LGBTQ+ and HIV activist, researcher, and project coordinator with experience of both national and regional levels. His work centers on LGBTQ+ rights, sexual health, HIV, and migration, with a strong focus on advocacy, research, and community empowerment. Currently serving as a project coordinator at Equality Movement, and is also at the regional level of in his country representative for the regional expert group on migration and health, contributing the knowledge exchange and policy discussions across Europe and Central Asia. And Iason, the floor is yours.
Thank you very much. Thank you for this introduction. And today I will talk about migration and HIV in Georgia, what kind of challenges, successes we have. And first of all, I want to talk a little bit about context that we have, HIV-related context. First of all, I want to mention that Georgia currently belongs to HIV/AIDS low prevalence countries. For example, we have only 10,000, 10,500 estimated number of people living with HIV/AIDS. But also, I should mention that the population of Georgia is approximately 3.5 million. So it's not a big country with a big population. Next slide, please. And here we see with some kind of dynamic of the HIV cases registered in Georgia annually. And here we also see a decrease and an increase of the registered cases, which according to the dates and year can be seen both with COVID or in the migration processes. I mean, after the war in Ukraine, and I will talk more about it a little bit later. Next slide, please. I mentioned that it's like a low prevalence country, but we have high prevalence when we talk about K populations, K groups, and here we see, for example, high level of the HIV prevalence in MSM population and trans community. And it's really important to mention because when we will talk about migration, it's also mostly associated with MSM population. Next slide, please. Mostly for Georgia, migration is not a typical process, mostly after the collapse of the Soviet Union, for example, many Georgians left for other countries. Georgia wasn't a receiver. So migration issues is something typically new for Georgia, and we can say it's some kind of new K population in Georgia in many ways, because many things changed after the war in Ukraine. And next slide, please. For example, here we see this kind of statistic, because according to the official statistics from the Georgian Ministry of Internal Affairs, approximately 62,300 Russian citizens entered Georgia in 2022, and also 20,700 Ukrainian nationals. Next slide, please. Okay. Here we see this kind of high numbers, especially the high when we talk about the number of population for Georgia. It's 3.5 million people. For example, I want to show you a total number, for example, of the Russian citizens. Next slide. Here we see a real big number for Georgia, and of course, it's affected to the dynamics associated with HIV related topical dynamics and different kind of situation and context that we have now. Next slide, please. And because like NGOs, governmental structures didn't ready this kinds of situation because mostly we had the services that created for example, Georgian citizens. It was always in Georgian, I mean a language, and adapted for Georgian citizens. But everything changed after this war in Ukraine and this migration processes. We had and have many migrants from K populations, like the Amazon population, especially from Russia and Belarus, and also from trans community. And then main barriers that we identified, first of all, it was a fear of prevailing one status, because they didn't know, they didn't have any kind of information about Georgia. Also, it was some kind of fear of being in a foreign country. For a big part of the migrants, especially from K populations, it was the first country, like for example, after Russia or Ukraine, and they have fears because of the traumas. For example, they had experience of the authoritarian dynamics and trauma associated with it in their countries, and of course the trauma associated with war, and of course it affected to their mental health. Yeah, of course it was in some way a language barrier. Of course it was an informational vacuum, because as I mentioned, everything before was created in Georgian. And of course, I can mention migrant syndrome, it's a stress, trauma, and full package of the problem associated with the mental health. Next slide, please. And what helps, yeah, because, for example, when we talk about HIV-related services, STI-related services, testing, etc., yeah, of course it's important, but when a person, when this, especially the gay populations, the vulnerable groups, have this kind of challenges, you need a multidisciplinary approach, yeah, and in the services of the social worker, legal and psychological support, and in some way humanitarian support, yeah, because we had many cases when people didn't have money for even a food, and in this case people didn't think about, for example, testing, didn't think about even about RV therapy. So it was a challenge, and there were some projects and programs associated with shelters, humanitarian support, and of course with the work of the social workers and mental health. Next slide, please. And what kind of tools we used, especially when we talk about HIV and STIs? Yeah, first of all, it was community intervention, active inclusion of group members. Yeah, because we did outreach, we identified group leaders, and with them we did all work. Also, it was convince and reduce bureaucracy, digitalization of the processes. For example, they can schedule visiting to the PrEP program. They also can, we can, for example, self-TSG platform, so they can order tests, condoms, and lubes, and it's easier, especially when person have some fears, when person have some traumas and stress, and also there's some language barriers. It's really easy for them. Of course, it's online outreach, because many migrants, in our case, created mailing groups, like in Telegram, for example, and it was a good space to spread the information and did the information intervention. And also, I wanted to mention a club outreach, because especially when we talk about Amazon population, it's an important space. And we also have experience when migrants itself created some party series, and we did a collaboration with them, yeah, with the self-test, with the condoms and gloves that we provided to them. And of course, information intervention consultations in a familiar language.
Jason, please,
yeah.
sorry for the interruption, but you have 1 minute left.
Okay, yeah. Next slide, please. Yeah. And so here, for example, we see previous. Yeah. Is for example, some statistics that we have to the prop access and use following the war in Ukraine. And it's like, as we see after the war in Ukraine, we have more and more people that are using PrEP after the Ukrainian Russian citizens. Next slide. And one of the reasons is, for example, that PrEP program includes free of charge, for example, periodic STD checkups, general blood and creatinine analysis, and, for example, free vaccination for hepatitis B. Yeah, for example, here we see also the SETW platform statistic. We don't have a clear statistic that will show a statistic about migrants or Georgian citizens, but we can say that half of these people are migrants. Next slide, please. And also, it's, for example, our coverage of the Muslim population with preventive packaging and testing by year. Here we also can say that 20-30% of these numbers are migrants and refugees in our case. But what I wanted to mention, the main barrier that we have not only in Georgia, but in our region is the geopolitical and political situation in our region, in Eastern Europe and Central Asia region. Next slide, please. Because we have this increasing authoritarian and anti-democratic sentiments. For example, we see that these new laws against communities and civil societies, anti-LGBTQI law packages and laws about agents. And it creates a situation where it's harder and harder to do our work, to create something new, to adapt, for example, our services or programs to a new vulnerable and children group like the migrants and refugees. So, future, to be honest, for us, a little different player. For example, for Central Asia, for Georgia, for Eastern Europe as well. And yeah, I think it's a good topic for discussions, how we can adapt our services to this kind of new reality. Next slide, and thank you for your attention and time. I will have to answer your question.
Thank you very much for all very interesting and amazing presentation. We saw ECDC presentation, Spain, Malta, the Netherlands, and Georgia, and all of our speakers had the information about the email address. So if you would like to contact with them directly, it will be also good opportunity to know more. We don't have too much time for question, but if any of you have any your urgent question, please put on the chat because we should finish in 2 minutes. I saw the one question from Julia, but I also saw that Charlotte already answered for the question about where we can submit country examples and practice, and Charlotte wrote about possibility to send that they open. Charlotte, can you say just 2 sentences about it for those who didn't read the chat?
Yes, absolutely. Thank you. I saw some question now from Jason as well. Great that you're interested in submitting examples of models of good practice. Please send me an email. I'll put it again in the chat, and you can just mention your name and your organization and the project name, and we'll make sure to add you to the list of interested actors wanting to submit models. Thank you.
Thank you very much. And unfortunately, probably I have to finish our webinar because of time, and most of you probably are also very busy persons. So we have to come to the end of the webinar. And before closing, I would like to thank today's presenters for sharing your knowledge, experience, and everything what you're doing and project that you presented. I would also like to thank all of you who have joined the webinar today for your presence and participation. As we mentioned, you will soon be able to find out the recording and this presentation on the website. And I would like to also thank Cecile and Sarah for all help and support for preparing this webinar. Thank you for joining us today, and happy European Testing Week, because we are still ongoing of the testing. I hope in your country the increase of testing happening right now, and European Testing Week spring version will be a huge success. Thank you very much, especially for the speakers and for you to joining us. Thanks.